Hello, everyone, and welcome. My name is Peter Monteleone. I'm an interventional cardiologist at the University of Texas at Austin Dell School of Medicine. I appreciate your time. Today, I'll be talking about my top 5 devices for lower extremity revascularization. These are my disclosures. This is a tough ask. As someone who's very dedicated and fascinated with device innovation and peripheral vascular intervention, there's a lot of devices that I am really excited about. I wasn't exactly sure how to pick my top 5, so I tried a couple of different ways. I thought about my top 5 devices on the shelf that have rescued me and helped prevent disaster, whether that's the spider embolic protection devices, whether that's covered stents, whether that's support wires like the Abbott Super Steel and Spartacore series, whether that's shockwave lithotripsy that helps us now do lithotripsy in situations where we can't do atherectomy. I thought about naming top 5 simple devices, things that I'm so thankful for that they've come into existence that always overperform. Terumo glide wires, the Ansel high flex sheaths. If you haven't tried these for very tortuous or complex iliac diseases going up and over, try them. Bright tip sheaths, letting us work close to sheath tips safely. The Fielder XT coronary wires that I feel like they can cross any microchannel they can see. The Terumo Takeda balloons, of kind of a newcomer for letting you cross with very low profile complex lesions, particularly in tibials. I settled, though, on talking about top 5 devices really in my practice, the devices that really impact what I do on a regular basis. And I start with this. The hand is the tool of the tools. What's important is not just the widget, but the operator's use of the device, and how those two things interact is really what becomes so important. So selection criteria, avoid the obvious, not a wire and a balloon. Speaking a little bit to tool classes, speaking of my personal practice, maybe thinking of some things that might inspire someone to try. Trying to stay a little bit data driven, but also mainly utility and clinical need driven, and try to move quick. So top 5 devices in my practice. Number 1, ultrasound. I direct our non-invasive vascular lab. Ultrasound is important before you ever get to the lab. It helps you find the lesions, find the patients, figure out how you're going to treat them. Lets you plan your procedure, plan your access, and limit the amount of contrast you give, including whether you're using carbon dioxide or not. Knowing where the lesion is and how to treat it is what's important before you even get to the suite. Use it for access every time. Learn from your radial and routine femoral coronary access. Use it for alternate access, whether it's sticking a tibiopedal or whether it's figuring out if the radial is big enough for radial or peripheral. Lets you improve your closure options, whether it's closure devices or whether it's decreasing your risks of hematoma by improving your access site and stick. And then use it after the procedural suite. Follow your patients post-procedure to make sure you optimize their care post. Your goal is to improve clinical outcomes, and ultrasound, in addition to make you better in the suite, helps you improve your clinical outcomes with utilization post-procedure. Number 2, maybe a little more controversial than ultrasound, drug-coated balloons. Drug-coated balloons, we've had so much discussion about safety in recent months and knocking on the door of years. No one, however, has doubted their efficacy, and thankfully the safety data is becoming more and more robust. Clinical efficacy, though, without doubt. So 12-month freedom from TLR, DCB over POVA without doubt across many studies. 24-month, even better, favoring drug-coated balloon therapies. Even in the patients whose outcomes are most severe, like critical limb ischemia, drug-coated balloon therapies. But even more than just data for TLR, operational utility of drug-coated balloons is remarkable. Lets you avoid permanent implants. It's an optimal treatment for no stent zones, common femorals, and popliteals. Lets us avoid needing to treat in-stent restenosis, where we're not very good in terms of our outcomes for in-stent restenosis. And by the way, DCB is probably your best therapy there. Lets us avoid the risk of scaffold thrombosis and acute limb ischemia. Lets us avoid putting stents upstream of severe tibial disease and poor outflow. So drug-coated balloons, based on the data and operational effect, really remarkably valuable, and certainly on my top 5. Next, Hawk 1, directional atherectomy from Medtronic. So atherectomy in general is extremely important. Directional atherectomy in particular is in my top 5. There's good data. So definitive LE looked purely at atherectomy, 800 patients, 600 claudicants, 200 CLI patients, demonstrated 78% primary patency at 12 months in claudicants, 71% in all CLI patients. Look at this, 78% primary patency for infrapopliteal treatment with directional atherectomy in CLI patients. That's not drug-coated therapy, that's not scaffold, it's just directional atherectomy. Pretty darn good. Operationally, directional atherectomy allows for vessel preparation to prevent dissection, prevent bailout stenting. Lets you treat in no stent zones and decrease the risk of bailout stenting in those territories. If you haven't used directional atherectomy since TurboHawk and SilverHawk, Hawk 1 is better. Crossing profile, cutting ability lets you tackle severe calcium. Directional in general lets you avoid microembolization. Also, it lets the team that is sterile, including you, the operator, completely set everything up and take it down. You don't have to rely on other people in the lab knowing how to use it. Next in my top 5, Cook's micropuncture pedal access set. Includes a micropuncture needle, micropuncture wire, and then the Cook Retro Tibeopedal access kit and sheath. There's a lot of different ways to go retro, ultrasound versus fluoro for access, 4 French regular sheaths, bareback without a sheath, using slender sheaths. What's important is knowing your kit, knowing its strengths, knowing its weaknesses, and picking your preferred choice. For me, it's this Cook Retro Tibeopedal kit. I always do the same thing. I try to be operationally boring and just make the same decisions. I start micropuncture needle, then micropuncture wire, then just the tiny little dilator, then a Boston Scientific V18. If I can cross retro at the V18, I just treat through the dilator. I never sheath that tibial. If I can't, then I sheath over the V18. That sheath lets me give vasodilators. That sheath lets me put a CXI 018 up and in place to allow for crossing. Knowing your device is what's important, and knowing what its strengths and its weaknesses are. This was a nice case. We treated an SFA CTO upstream of this tibial disease. This was a patient with critical limb ischemia with a toe wound. They also had this discrete short mid-segment AT occlusion. We couldn't get across it antegrade. We stuck the AT distally, couldn't get across it retro. Now there's a V18 through a CXI 018 coming up the AT. When we couldn't get across, we then did balloon angioplasty proximally, a little reverse cart that let us smoothly cross with that V18 from retro. This was a very tall person. They were about 6'6", didn't have the ability to body floss secondary to length of device. And so what we did is we were able to get a coronary balloon up through the foot. We did some balloon angioplasty retrograde through the AT that let us smoothly get an 014 nitrix wire down from antegrade across the track we'd ballooned open. We did a little 30/80 nanocross treatment of the AT with an excellent angiographic result. Turned out very well, and we were able to do it because we knew exactly what strengths our kit had to offer. Number 5, carbon dioxide angiography via CO2 Mander. Chronic kidney disease is incredibly prevalent in patients with PAD. Being able to treat these patients with minimal contrast is extremely beneficial. You don't need CO2 Mander to do CO2 angiography. We jerry-rigged something back in the day using stopcocks and 30 cc syringes attached to the carbon dioxide tank from surgery. Eventually we got fancy and attached an IV bag and used that because we had a one-way stopcock to allow for safety. Now we use CO2 Mander, quick, easy, effective. As a result, we're very quick to use carbon dioxide. We use it in patients with, creatinine of 1.5 and just minimize our total contrast dye. Really a great device to have on the shelf. Here's a nice case. Access CO2 picture, aortoiliac CO2 picture, up and over, found the lesion. Used a little contrast to identify the lesion. This is a great case because after that we crossed. We used Hawk 1 directional atherectomy to vessel prep. We used an impact drug-coated balloon to vessel treat. 15 cc's of contrast for the whole thing. This really speaks to my practice. Lots of complex disease, CTO disease, treating it using a bunch of the devices that I've had on my list for discussion here. So thank you all so much. I appreciate the opportunity to talk about my top 5 devices for lower extremity revascularization. If any questions, I'm always available for contacting and further discussion. So thank you for your time.